morning. My name is Kristen Talbot. I'm the program manager for MAVEN Project. Thank you all for joining us today and our friends at Generations Family Health Center for hosting today's session, Adolescents with Bleeding Disorders, Who, What, and How to Treat with Dr. Joanna Davis. Dr. Davis started the Pediatric Hemophilia Treatment Center at the University of Miami and has remained the medical director until this month, where she is transitioning to director words today, of the Hemophilia Treatment Center. While remaining as voluntary faculty at UM, she will continue to provide education and program development for healthcare providers and community groups. And we are just so lucky at MAVEN Project to have her as one of our volunteers. So Dr. Davis, when you're ready, please begin.
Okay. Well, thank you very much for the opportunity to talk about something which I can talk about incessantly, which is bleeding disorders, and in particular, teenage girls with bleeding disorders, because this is something which over the course of the 37 years that I was running the Hemophilia Treatment Center, I saw an evolution in how we as a treating community look upon women with bleeding disorders. And I'll touch on that in the course of this. But I do know that many primary care providers, whether it's pediatrics, adolescent medicine, internal medicine, family medicine, are dealing with these girls who are coming in with heavy periods. And there has, as I said, been a change in terms of how we look at these girls to try to understand why they are experiencing the kind of menstrual issues that they are. These are my disclosures. And you heard all about this from Kristen. And these are just some of the learning objectives. And it's a lot, but hopefully this will all kind of make sense as we go on. So to identify when to evaluate patients with heavy menstrual bleeding. What is heavy menstrual bleeding? Right? I mean, that is something which we work very hard with our trainees to get them to understand what that really does mean. To recognize von Willebrand disease using clinical assessment measures and laboratory testing, according to evidence-based practices. As I will discuss later, von Willebrand's disease is the most common bleeding disorder in the universe. And it is not unusual when you're evaluating a girl with heavy periods to find out that she does indeed have one of the types of von Willebrand's disease. Try to develop a therapeutic approach to the girl who is bleeding significantly. How can we as primary care providers interface with this? Maybe we don't have access to a hemophilia treatment center with a girls' clinic, which is something we started a few years ago in conjunction with adolescent GYN. Maybe you don't have instant access to an adolescent GYN. And it's important to understand how adolescent medicine physicians can support these young women and serve truly as the front line. So again, more practical tools, which I think as we go through the talk will become more apparent. So I'm going to use a case which is based on a conglomerate of real patients, just to sort of start the conversation going. So this is Molly and her mortifying menses. 14-year-old presents as an urgent visit to your clinic, referred by her pediatrician. She had been sent home from school, having flooded through her clothes during her period. And it turns out that this has happened every period for the past year. By the way, her mothers, sisters, and aunts, all on mom's side, report heavy periods. So I, as the front line, know that this girl probably has a bleeding disorder, but she's 14. What has caused this delay in recognition and diagnosis? And this is a reality check. And as I said, there's been an evolution in how we regard women who have bleeding challenges. Even to this day, many practitioners will tell me, no, bleeding disorders are only for men. Women don't have bleeding disorders. And this is because for decades, the focus was on hemophilia A, hemophilia B, which are predominantly male disorders, but as we'll talk about, women have hemophilia too. So statistically, there are about 1 million women and girls in the United States who have a bleeding disorder, but only about 20,000 know that they have it. Fortunately, that number is changing with increased recognition and awareness. The most common reasons that women seek medical attention, besides being pregnant, are heavy menstrual bleeding, now used to be called menorrhagia, now it's heavy menstrual bleeding, or HMB, or iron deficiency anemia, abbreviated IDA. 20 to 30% of women with heavy menstrual bleeding will turn out to have an undiagnosed bleeding disorder. 15 to 25% of women with iron deficiency anemia may be found to have an undiagnosed bleeding disorder. Now, the specifics of the management may not be different in terms of how am I going to stop the bleeding, how am I going to treat the iron deficiency. But as I explained to families, it really is important to know. First of all, it's a partial or it's an explanation, which makes everybody feel better. But the other thing is that this young woman does not exist in a vacuum. She may need wisdom teeth extraction. She may be in a motor vehicle accident. She may need emergency surgery. And it is incumbent upon us to make sure that she understands her medical history so that there can be a communication with other providers in critical situations. So these are the bleeding disorders common in women. Von Willebrand disease, we'll talk more about that. The most common disorder worldwide, male, female, black, white, green, pink, plaid, Jewish, Christian, doesn't matter. 1 to 3% of the world has von Willebrand's disease. Most people don't know they have it. Hemophilia A or B carrier is the second most common bleeding disorder identified in women. What is important is to realize that women who carry the gene for hemophilia A and B may be asymptomatic, what has been called silent carriers, but they may have low factor 8 or 9 levels. They may have bleeding symptoms and actually fall into the category of having mild hemophilia. And we'll talk more about that later. There are some other factor deficiencies and bleeding disorders that we do see not uncommonly. Factor 7 deficiency, factor 11 deficiency. There are other rare factor deficiencies, factor 13, factor 5, factor 10. Defects in the fibrinolytic pathway. As I explain it to patients, we have two systems at play here. We have the clot forming system, right? If you're bleeding, you want to stop bleeding, and that's where clots come in. But we also have the clot busting system. We do not want clots to stay around forever and ever. We all know the risks of venous thromboembolic disease. We don't want them to break off. We don't want them to grow. So as soon as a clot is formed, the other system, the fibrinolytic system, kicks in. There are people who have problems with their fibrinolytic system so that they actually may not have functional proteins involved with that, and that can cause issues as well. There are people who are born with abnormal platelets. They don't work right. There's a ton of different inherited platelet dysfunctions. The most common ones, which we're not going to talk about, but you may have heard of, are Bernard-Soulier syndrome and Glanzmann's thrombasthenia. So what happens when we are bleeding? And it doesn't matter why we're bleeding. It could be somebody picked their nose. It could be a menstrual period. It could be surgical bleeding. There are three things that happen all at the same time. The first thing that happens is that the blood vessel, which has had a breach in the endothelial layer, so that's why it's bleeding, it's leaking, tries to close on its own. And this doesn't do very much, but it starts the whole ball rolling. Simultaneously, the platelets are activated. I explain to my patients, platelets are little tiny pieces of cells. They're sticky. They're like Velcro. And like Velcro, their job is to stick. So when there is an injury and the blood vessel is squeezing, the platelets are directed with the help of the big von Willebrand protein to stick to the basement membrane where the endothelial layer is disrupted. So they stick to each other, a process called adhesion, and they pile up and that's called aggregation. So after you have this, the adhesion of the platelets to the basement membrane and the aggregation of the platelets, you have the formation of a primary platelet plug. This is primary hemostasis, vasoconstriction and activation of the platelets. If you look at this platelet plug under an electron microscope, you will see that there are gaps between the platelets. And that's kind of like Velcro, right? They've got the two pieces with little hairs, and it's very easy to pull apart. Something has to happen to fill in the gap between the Velcro platelets to make the clot tight. And that's where the secondary or fluid phase of coagulation, of hemostasis, comes into play. That is the predictable, orderly activation of a series of clotting proteins or factors, so that at the end of the whole process, which is about 35 seconds, there is the formation of a substance called fibrin, which is a biological glue or cement, which fills in the gaps between the Velcro platelets and makes the clot tight. And this is just a scanning electron microscope showing you the platelets embedded in this fibrin mesh. Now, why has it taken so long to recognize that a woman may have a bleeding disorder? This is a great article if anybody is interested. Sexism in the management of bleeding disorders. There's the lack of knowledge that women have bleeding disorders. There's a focus on men and hemophilia. And until recently, and recently is within the last 5 years, maybe 6, fewer resources for women and girls. A lack of awareness that hemophilia A or B carriers can bleed. Everybody's heard of the lion hypothesis, right? During embryogenesis in a female, one X chromosome at random is inactivated in every single cell of her body. This is now called skewed X inactivation. And if you think about it, if you conceive of, as I explained to families, a woman is made of 10 cells, and she is genotypically, she is carrying in each of her cells the genetic mutation on an X chromosome, which says, don't make factor VIII, don't make factor IX. If at random, in 9 of her cells, the abnormal X is shut off, then she's going to be functioning basically with normal X chromosome, right? We don't need 2 X chromosomes up and running as females, right? That's overkill. So in that situation, you have a woman who will have normal factor levels, won't have bleeding, and phenotypically will be normal. She may not even know that she's carrying that gene until she has a hemophilic son. Silent carriers, asymptomatic carriers, that terminology has been around forever. But now take the other tack of your 10-cell woman. Now, in 9 out of her 10 cells, the normal X is shut off. She's functioning basically with X chromosomes that say don't make a lot of factor VIII or factor IX. I'm not a mathematician. You have to do all of these calculations to try to figure out what her level may or may not be. Bottom line is, she will have low factor levels. She will probably have bleeding symptoms. And she will fit the category of being a mild hemophilia patient based on her factor levels. Women who are carriers, even if they have pretty close to normal levels, right, that mystical, magical 50 to 150%, will still have more bleeding than a male with hemophilia at the same level. And these are 2 objective measures of trying to determine how much bleeding a woman will do. One is a BAT, a bleeding assessment tool. There's a ton of them. Google it. They're as complicated or simple as, there's a whole gamut of them. You can even get self-BATs, which we have our girls do in the waiting room while they're waiting for one of us to come in, right? It's a QR code, and they can just answer these basic questions. But it's asking about different types of bleeding. Nosebleeds, how much, how often, provoked, unprovoked, menstrual periods, surgical bleeding. And it's scored. And you can see on this slide here that in women who are not affected by a bleeding disorder, their BAT score was about 1. But in hemophilia A carriers, and this can be women with pretty normal levels, but they are still genotypically carriers, look at the difference in their bleeding assessment score. The PBAC, pictorial bleeding assessment chart, is specific for menstrual bleeding. And it basically is asking women to describe on a daily basis during their period, how many pads are they using? How many tampons are they using? How saturated are they when they change? And again, this is something we give to our girls while they're sitting there. You know, we give them the PBAC and a red pen that they get to take home, and they sort of draw on the chart what kind of saturation of their pads or tampons they have. And then there's a scoring system. For normal women, basically it's maybe 150-ish, but for hemophilia A carriers, it's right up there. So you can see that even with the carrier status, carriers do have bleeding. In 1923, the first case in the literature of a woman with hemophilia was reported. She was diagnosed in middle age. She bled significantly with a tooth extraction. She had multiple hemorrhagic episodes, including heavy menstrual bleeding. But there was no further mention in the literature of a female carrier until 25 years later. In 1925, Erik von Willebrand identified a family in the Åland Islands off of Finland with what we now call von Willebrand's disease, which is a different disorder from hemophilia. On average, there is a delay of 16 years between the onset of symptoms and the diagnosis of a bleeding disorder in a female. If you look at hemophilia males, those who are severe, those who don't make a lot of any factor 8 or factor 9, they're picked up in the first month or 2 of life. The moderates, 1 to 5% activity, they're picked up certainly by the time they're toddlers. The milds, there's a longer gap because they may not have significant bleeding unless challenged. But it's not 16 years. We did a study at UM, one of our fellows who has since gone into hemostasis, did a retrospective study looking at 100 girls who were identified or admitted between 2015 and 2021 with heavy menstrual bleeding or iron deficiency anemia. And of those 100, 46 were diagnosed with an underlying bleeding disorder. And even in a place like our center, which has had a hemophilia treatment program since 1987, which has had a girls' clinic now for the last 2 to 3 years, the average time to diagnosis from menarche with these girls was 4.5 years. So clearly a disconnect. And it is imperative for us as treaters to think about this when we are confronted with a girl with unusually heavy menstrual bleeding. This is just the float, the pedigree for that family with von Willebrand's disease. And the proband child bled to death during her 4th menstrual period. So let's talk more about von Willebrand's. It is the most common inherited bleeding disorder, 1 to 3% of the population worldwide. But the bleeding symptoms are usually not enough to yield a diagnosis. Males and females are equally effective, but females, because of reproductive bleeding, which is either menstrual periods or postpartum bleeding, are disproportionately burdened. What's interesting is that in everybody, as we age, our levels of the von Willebrand protein increase. And in males, for whom the primary symptom may be nosebleeds, they very commonly will say, oh, I had nosebleeds as a child, but I outgrew it. Well, the levels may have risen to the point in a male that that challenge is no longer an issue. But we do know that the tendency to bleeding persists throughout a lifetime, regardless of whether or not the laboratory numbers have risen to the normal range. For women, for girls, even though they also undergo this rise, age-related rise in von Willebrand protein, the burden of reproductive bleeding overtakes whatever rise there is. There are 3 subtypes of von Willebrand's disease: type 1, type 2, type 3. And what is also interesting is that the presentation is very variable. It is variable within an individual patient within her lifetime. I had a girl who was 19, perfectly fine. She was one of these competitive bikers. She was bike riding on these little skinny seats and going up and down hills and things that I would never do, but no problem. Periods were great. Everything was fine. She got off her bike at 19 and was black and blue from her buttocks down to the back of her knees. Had never happened before. Everybody was obviously concerned. There was a concern, could she have a marrow infiltrative process? Turned out she had von Willebrand's disease. No previous nosebleeds, never bruised easily, periods were 3 days, no problem, but bingo, there it was. And she continued to have issues for a year or two with unusual bruising, and then that went away. And when she was 26 or 27, all of a sudden she started having periods that were lasting 2 weeks. Much of the bleeding with von Willebrand's is what we call nuisance bleeding, right? Nosebleeds, bruising, nothing overt. Sometimes you'll get a kid who had a tonsillectomy and then they have to go back to the OR because on day 7, the eschar falls off and then they're bleeding. But it's usually not anything which will prevent somebody, usually, from going about their business. Yeah, you'll miss a few days of school or something like that because your periods are terrible. But there's a tendency of the medical establishment to also take the approach, well, of course your periods are bad. Of course you have iron deficiency. You're female. The other thing which delays the diagnosis is this is inherited. And I can't tell you how many times I get the story, oh yeah, my mom had periods that lasted for 2 weeks and she had a hysterectomy when she was 37 because they couldn't stop the bleeding, or, it's normal for the family. And this is why when we take a family history, we have to be very, very targeted. So type 1 von Willebrand's disease is the most common. 75%, 80% of people have type 1. This is usually considered mild, although there are degrees of severity with that. It's an autosomal dominant. It's a quantitative deficiency. These people make a less than normal amount of a functionally normal von Willebrand protein. And the von Willebrand protein wears many hats. It's huge. It has to bind to the basement membrane. It has to have an affinity for collagen, because in that first stage of primary hemostasis, the big von Willebrand's protein goes glomping down onto the endothelium to serve as a Band-Aid. It has binding sites for platelets. It attracts the platelets, right? So it's important to serve as a beacon to build that platelet scaffold. It has binding sites for clotting factor 8. Clotting factor 8 is what is deficient in patients with classical hemophilia or hemophilia A. Factor 8 is a very small protein. If left to its own devices, it would be cleared out of the circulation pretty fast, and we'd all have severe hemophilia A. So the binding of factor 8 to von Willebrand's factor allows the extension of the survival of factor 8 in the circulation. And the symptoms for type 1 are usually pretty mild, right? Bruising, maybe nosebleeds, gum bleeding when you brush your teeth, hematomas with IM shots, and period bleeding. The other quantitative von Willebrand disease is type 3. Opposite end of the spectrum, it's also called severe von Willebrand's disease, and it's pretty rare, maybe 1 in a million. This is autosomal recessive. There is a complete deficiency of von Willebrand's factor. And if you don't have von Willebrand's factor, your factor 8 has no place to go. So it gets cleared out also. Even though the person can manufacture factor 8, it just gets cleared out. So people with type 3 actually have the worst of both worlds, right? They have all of this mucosal bleeding that you get with von Willebrand's, but they also bleed like hemophiliacs because they have no factor 8. So they will get big intramuscular hematomas or joint bleeds. And it's very important when we are dealing with a woman and we start to pick up low factor levels, we need to make sure that we're not dealing with one of these variants of von Willebrand's disease. The type 2s are autosomal dominant. There's lots of different types. They each reflect a defect in the ability of the von Willebrand protein to bind either to collagen or to factor VIII or to platelets. It's qualitative. The numbers, when you do your von Willebrand protein, you're measuring von Willebrand factor, those may be normal, but this protein doesn't work well. And this is where doing a more specific evaluation of the von Willebrand's protein, called the multimers, the building blocks of the big von Willebrand's protein, becomes critical for differentiating whether you're dealing with a type 1, type 3 becomes pretty obvious because everything's 0, or a type 2. So hemophilia, as we've said, is an X-linked recessive disorder. It's an absence of either factor VIII, which is classical hemophilia, or factor IX. Factor IX is also called hemophilia B or Christmas disease. There's a difference in the incidence of it. Hemophilia A is 1 in every 5,000 to 7,000 live male births. Again, equal opportunity disorders across the globe. Factor IX deficiency, 1 in every 25 to 30,000 live male births. And we grade the hemophilias and pretty much all of the coagulation deficiencies on the amount of the protein detectable in the plasma. The severes in hemophilia make no detectable factor. These are the ones that got all the attention, right? These are the people at risk for life or limb-threatening bleeding with little or no trauma, joint bleeds. This is the patient population back in the 80s, which was relying on factor replacement therapy with pooled human plasma and factor concentrates, and ended up with HIV and hepatitis C. Moderates, 1 to 5%, they may have bleeding symptoms, certainly with trauma, but they are less likely to have spontaneous joint bleeds, spontaneous intracranial hemorrhage. And the milds, again, it's actually, there's been a change. 5 to 40% is considered mild. 40 to 50%, the World Federation of Hemophilia decided to call them near normal. This has implications for activities. We may not see these patients unless they come for surgical screening and their PTT is prolonged. What's the inheritance? Well, this is the classical one. Dad's a hemophiliac, right? He's got that hemophilia X. He doesn't have another one to balance it. And all of his daughters, because he only can give an X, will be what we call obligate carriers. Doesn't tell us whether they're going to have low levels, doesn't tell us if they're going to be symptomatic, but genetically, all of his daughters will be obligate carriers. None of his sons, right? Because you need a Y to make a son, and mom has no problem, so there you go. Now let's take this woman, this obligate carrier, we're going to look at her over here. She is marrying an unaffected man. And any female she conceives has a 50-50 chance of getting the hemophilia gene and a 50-50 chance of being a carrier. Any male she conceives has a 50-50 chance of getting the hemophilia gene and of being a hemophiliac. So Molly turns out to be very shy, doesn't like talking about her periods, hates having her blood drawn, and is terrified of needles. So what do we need to ask? What labs do we need? And what is the implication for the results we get? I love this slide. The American College of Obstetrics and Gynecology have come up with this menstrual periods as a vital sign. And this is, as of 2015, this is what was being reported as considered normal. Menarche, median age 12.43 years, mean cycle interval 32.2 days in the first gynecologic year, interval 21 to 45 days. Menstrual flow length 7 days or less, and the menstrual product use 3 to 6 pads or tampons per day. This is what I was talking about with the PBAC. Okay, in terms of how our girls fill out these pads. You can see the difference between just scant spotting and a saturated pad. One question that I always ask when I'm doing a menstrual history is, what kind of product are you using? Because if you're only using mini pads, the absorbency is not going to be particularly robust. If you're telling me that you're using double overnight pads and changing them every hour for the first 3 days of your period, and they're soaked and you're flooding your clothes, that's significant. So I always make sure to ask that kind of a question. So what constitutes heavy menstrual bleeding? Bleeding for more than 7 days, flooding or gushing blood that limits activities such as social activities, school, or exercise, passing blood clots not once in a while, but this is kind of the norm, that are bigger than a quarter, changing a tampon or pad every hour or less, at least on the heaviest day, if not more than that, and the product is saturated, iron deficiency or prior anemia needing treatment, and realize that an average menstrual cycle should not be more than 80 milliliters of blood loss per cycle, and even that constitutes to at least 35 milligrams of iron loss per period. And I found this to be really very important for those of us who work in a primary care setting. According to the International OBGYN Society in Europe, if the girl says her periods are too heavy, it's too heavy. Doesn't matter if it turns out that it really isn't, but it is incumbent upon us to pursue this for our patient. History, very important. Other clues, any anemia symptoms or a history of anemia, especially iron deficiency. This is part of the bleeding assessment tool. Nosebleeds, gum bleeding, easy bruising, family history of bleeding symptoms and bleeding disorders, particularly heavy menses or postpartum hemorrhage in female relatives, nosebleeds in male relatives. A nosebleed in a child under the age of 2 is pathologic. That's a red flag for a bleeding disorder. The story of nosebleeds, my father had nosebleeds as a kid and he outgrew them by the time he was 15 or 16. That's also pretty typical, as I mentioned before. When I ask a family history about women in the family, I'm very careful to say any women on either side with a history of periods for which she was recommended or underwent blood transfusion, IV iron, or hysterectomy as management of heavy periods or postpartum bleeding. And it's pretty amazing when you put it in those terms, all of a sudden, people remember, yes, you know, my aunt, she had a hysterectomy, she was 35, and that sort of thing. But that's very important information. Clearly, we want to know about the girl's GYN history. We also need to know about her other aspects of her past medical history. We want to make sure that there's no history of migraines with aura, a history of DVT, because we will be using estrogens most of the time to manage her periods. And these are all just, you know, basic good parts of the medical history. This is something which I give a shout out to our adolescent GYN, and I'm sure you're all familiar with this HEADS interview. Right? Home, education, employment, eating, activities, drugs, sexuality, suicidal ideation, safety. It's amazing, and I think we all know this, but it's amazing how much a significant stress can mess up a girl's cycle and cause heavy bleeding, irregular bleeding. So we are definitely within our girls' clinic making sure that this interview is done and recorded. So what do we order for this girl, this 14-year-old girl? Well, you always want to rule out a pregnancy. She may be shy, but you never know. You do CBC diff, retic, and a platelet count. You don't want to miss a thrombocytopenia. You don't want to miss an infiltrative marrow disease. You want to know if she is anemic. If her hemoglobin is under 7 or she's symptomatic in terms of cardiovascular symptoms, you will get a type and cross. You do an iron profile, which includes, in our institution, ferritin, iron, and TIBC, transferrin saturation. It's the ferritin that we really focus most on. The ferritin is a reflection of iron stores. Serum iron can be normal, depending on what her diet is and everything else, but it's looking at that ferritin, which gives you a history. We do a PT and a PTT, right? These are measurements of the ability of the patient's blood to clot in a test tube, and it is a reflection of that secondary hemostasis or the clotting cascade. Patients with von Willebrand's disease will have a variably prolonged PTT. That's the intrinsic pathway. Patients who have factor 7 deficiency will have a prolonged pro-time. So the PT pathway, the extrinsic pathway, which is the one that jumpstarts coagulation, is pretty much a reflection of clotting factor 7. We do a von Willebrand panel. Again, the activity, the interfacing with platelets, which is the ristocetin cofactor. We always look at factor 8, right? Because it lives with the von Willebrand's protein. We want to get the von Willebrand multimers. We want to know how this protein is built. But the chances are that we will need to repeat this at least once, if not twice, even if the numbers are normal. The von Willebrand protein is an acute phase reactant, and under stress conditions, it can be falsely elevated. So we really want to get a good handle on it. We'll do a factor 7 activity level. We've started just doing that because in that article that I referenced, we found that of the 46 girls with heavy menstrual bleeding and a diagnosed bleeding disorder, literally half of them had factor 7 deficiency. This, in our area, there's a very high concentration of patients who are from Guatemalan Indians, and they have a very high incidence of factor 7 deficiency. Factor 11 deficiency is also something which, again, I always ask, where's the family from? Usually then saying, please don't say Florida, because all it takes is one Eastern European Jewish grandma, and you may have that gene for factor 11 deficiency. If her periods are irregular, we get TSH. If she's obese, has hirsutism and irregular cycles, we always check an A1C, testosterone, DHEA sulfate, prolactin level, because this can lead to the diagnosis of PCOS. If she's sexually active, we want to make sure that she doesn't have GC or chlamydia, which will become important if we're going to use an IUD. What about an ultrasound? It can provide information about endometrial thickness, which is important from a GYN perspective. It will look for developmental abnormalities like this, like a bicornuate uterus. It's unusual to have fibroids, but it can occur. Occasionally, you'll pick up an estrogen-producing malignancy. But the bottom line is that you really want to treat the problem, the heavy bleeding. So if you can't get an ultrasound, and these are external ultrasounds, right? It's very unusual for our GYN to even do an internal exam. Everything is done outside. You don't delay. Address the issue and manage it. So now here comes Molly's sister. She's 11, and she was admitted to the hospital with a hemoglobin of 5.4. She presented with the same history of heavy periods, was found to have severe anemia, and was admitted. In the hospital, her PTT was 34 seconds, which was slightly prolonged for the lab. It's not enough to say, oh yeah, it's basically normal. Again, it's von Willebrand protein, factor 8. These are acute phase reactants. And in stress conditions, they're going to go up. And if they're going to go up, they may well normalize or almost normalize your basic screening tool of the PTT. So you drew bleeding disorder studies, and now what do? This is probably, in my opinion, one of the most important slides. And I'm glad you get the slide deck. This is how we assess and manage our girls who are showing up with heavy periods. And this was developed in conjunction with our fantastic adolescent GYN. The phone numbers at the bottom are obviously peculiar to the university. But again, it does give you sort of instructions or a roadmap at least to follow until such point in time as you can interface with a gynecologist. We don't routinely transfuse these girls unless their hemoglobin is under 7 or they have orthostatic hypotension, tachycardia, or they're actively bleeding heavily. Okay, these are healthy girls in general, and teens can withstand if hemoglobins of 5 and 6, especially if you get them on some kind of iron replacement therapy. If you're going to transfuse, we do 1 unit. We don't do 2. We are concerned about the potential for isoimmunization so that when this girl is pregnant and has a baby, we don't want to have added the risk of a hemolytic process to that. We would stabilize her with crystalloid. If at all possible, we would like to draw the bleeding workup before hormone therapy is started, because estrogens in particular will falsely elevate the von Willebrand panel, falsely elevate the factor VIII. And this is a real conundrum when we get girls referred in from somebody and they're already on oral contraceptives and estrogens. When do we do this bleeding workup? We want to stop the bleeding. So we use a taper, an oral contraceptive taper. In general, I'm not a gynecologist. This is just sort of broad strokes, starting QID for 48 hours, then TID, and then switching down for a couple of days, going down to twice a day. Or we use IV Premarin every 6 hours until the bleeding stops, and then switch to an oral contraceptive. You want to use a monophasic pill with at least 30 micrograms of ethinyl estradiol, preferably levonorgestrel or norgestrel. The estrogen is the most important part. Start every 6 hours if you're going to do this orally, taper to every 8 hours, and skip the placebo. This stuff is going to make girls throw up. Make sure that they have an antiemetic. What if it's someone who has a contraindication to estrogen? Everybody in her family has had, blood clots. So continuous oral medroxyprogesterone, norethindrone acetate. This is not the mini pill. This is not a contraceptive. Brand name is Agestin. You start her out at 10 milligrams twice a day, and when the period stops, you can try cutting her down to 10 milligrams once a day for a couple of cycles. And if she's still not having any bleeding, and that's what you really want, you don't want her to be bleeding, you can go down to 5 milligrams a day, and you can titrate in the course of a month. I have girls who are on 5 milligrams a day. They find out that they have a bad period, a heavy period, and it's going on longer than they like, and they bump up to 2 pills a day, to 10 milligrams a day for a couple of weeks, and then that calms it down. We try to avoid Depo-Provera because, again, we don't know if this girl has a bleeding disorder, and an IM shot can cause a muscle bleed. We talked about the fibrinolytic system. There are medications that delay the breakdown, right? And this just discusses how it works. And the antifibrinolytics block the conversion of plasminogen to plasmin. Plasmin is what busts up a clot, and therefore the integrity of the fibrin mesh is preserved for a while. There are 2 out on the market. One of them is Amicar, amino epsilon capronic acid, and we use that a lot in head and neck procedures and GI procedures. But increasingly, we are relying on tranexamic acid. This is labeled in this country for use in heavy menstrual bleeding. And this is very often a first line of defense that we use, or our trainees use, because it's non-hormonal, it's not a birth control pill. And this is used, there's 650 milligram tablets, 2 PO TID for the first 5 days of each period. Patients like it. It's useful for any kind of what we used to call dysfunctional uterine bleeding. And it's very, very helpful in managing a period in adolescents with heavy periods, regardless of cause. And it is important to know that it is safe to use even with a combined oral contraceptive that has estrogen. That's a myth that's out there. No, you can't take it because you're going to get blood clots. It is safe to use with estrogen. Don't forget iron therapy. You have to really make sure that your girls understand the need for it. They should ideally take it with food or vitamin C to improve absorption. Try to avoid taking it with a glass of milk because the calcium will compete with it. But increasingly, we are finding a lot of girls who are experiencing significant GI discomfort, and we're switching them over to intravenous iron. Again, transfuse only for severe symptoms, not a hemoglobin number. So now Millie is found to have a low von Willebrand antigen in the hospital. So just think about it. What else would you do? When would you do it? How would you manage her period long term? In general, for a girl like that, we would do a little bit more specific probing into the von Willebrand protein. Again, remember, it was done in a stress situation. We would definitely repeat everything, but we would do a more specific look at the collagen binding. And that's something which is not part of an initial panel. We also might go on for von Willebrand genetics. Now, there's thousands of mutations that can give you von Willebrand's disease. The genetics may be helpful. We definitely do family. We push on the family to try to get a better handle on it. Sometimes we'll even be able to order labs on a sibling or a parent to try to clarify things. In terms of long-term management, in addition to the tranexamic acid, which may be all that this girl needs, but in general, we're going to look at hormonal interventions, and the levonorgestrel IUDs are something which our GYN feels very, very strongly about. There are a number of them. She uses it. The risk of PID is increased only around the time of insertion. They're tiny. That's one of the reasons we want to document chlamydia and gonorrhea status prior to insertion. If there are infections, we want to treat them. And it has been shown to have a greater reduction in menstrual blood loss, 86 to 97%, than antifibrinolytics alone, oral contraceptives alone, or prostaglandin synthetase inhibitors. Our gynecologist uses this in virginal girls, and she makes sure that they're very relaxed. It's kind of like going to a spa when she puts it in. And the girls themselves say they thought it was going to be terrible, and it wasn't. And after, certainly after a cycle or so, they're very, very pleased. And they may not bleed at all. Timing the testing for repeat testing, again, if they're on oral contraceptives, we usually wait for the day. If they're on a placebo, we usually wait for the day that they're due to start. We have them come in, or we send them to Quest or LabCorp that day. Don't start your regular pill until you've had the blood work done. Always consult a hematologist for additional testing. And again, collagen binding assay or gene therapy or gene mutation analysis. Sometimes girls have two things. We have a number of patients who are combined factor 7 von Willebrand's. They're inherited on different chromosomes, or combined factor 11 and von Willebrand's, or factor 7 and 11. And these are things which we are learning as we are doing increasing numbers of genetic testing and thinking about getting these levels. And it's important in a pediatric population to make sure that you are looking at values from your lab that are age-based. You can get age-related tables for any of the clotting factors. And again, knee-jerk, 50 to 150% is normal. Well, actually, in certain ages, with certain particular factor deficiencies, 55% may be clearly low for age. And now you've got someone who's bleeding and they have a low for age factor 7. Well, guess what? Even though it's in the 50 to 150%, they have this as a deficiency. Always, if you can, consult a hematologist, not just through the MAVEN network, which I am thrilled about and happy to be part of this, but if you go to cdc.gov, cdc.gov, that will bring up a hemophilia treatment center directory for all of the federally funded hemophilia treatment centers in the United States. You can plug in your zip code, you can plug in your city, you can plug in your state, and you can get contact information for the closest HTC in your area. And the staff there will be very willing to provide you with context, with contact, with suggestions. So the Hemophilia Treatment Center, when I first started this, it was male dominated, right? The concept of comprehensive care started with the bleeding disorders community. It has since expanded, right? Everybody is looking for comprehensive care. What do these patients need? And for women in particular, it includes OBGYN. In addition to a hematologist, pediatrician, internal medicine, a lab that knows how to do these tests, psychology, because there's a lot of psychological overlay regardless of the bleeding disorder diagnosis, access to genetics, a pharmacy or a pharmacist who is familiar with the medications that may be recommended, anesthesia who is not panicking when they hear that somebody has von Willebrand's disease. But the primary role of the HTC, in addition to supporting patients, is to educate primary care providers about women with bleeding disorders and to educate the women themselves about what they have. We can use medical resources efficiently We are supporting nationally the development and implementation of women's programs. We provide prenatal care, pregnancy, delivery plan, coordinate surgeries, co-manage heavy menstrual bleeding. We don't want to take your patients, but we want to work with you. And in that way, we establish a dialogue where the patient is at the center of this. We do a lot of talking, as you can tell, but things have improved significantly with women with bleeding disorders, girls with heavy periods. So I'm going to stop. And if there are any questions, I'm happy to entertain it. Kristen says you're going to have the slide deck. And again, I'm happy to answer questions or to hear your experiences.
All right, Dr. Davis, thank you so much. Just a reminder, if you have any questions, use the Q&A box, chat box, use the raise hand feature for big words. We'll start with the first question. You mentioned variable presentation in an older adolescent or woman who reports unusual bleeding, bruising, or menses. Should we check for VWD then? I don't check usually if late presentation.
Yes, I would. When you have, and again, this is where the bleeding assessment tool may be something which will help you ask your history or make you more comfortable with the idea of pursuing this. But yeah, variable presentation. People can have no problem, and then they show up with something in their late teens, early 20s. And it's important, obviously, when you ask, have you ever had nosebleeds? Well, I usually say, I don't mean once in a while. Have you had periods of time where you're having nosebleeds every week, a couple of times a week, a couple of times a month? Are they provoked or unprovoked? What do you do to stop it? And nosebleeds are a big deal, right? It's really something which people don't often think about in terms of maybe it's not people, physicians, but family members. Everyone has nosebleeds. But absolutely, if you're confronted with an adolescent, a young adult who all of a sudden out of nowhere is having bleeding, bruising symptoms, heavy menstrual bleeding, part of your workup should be looking for the most common bleeding disorder. Now, if you find out that this girl is an Eastern European Jewish extraction and all the women in her family have this, that will also inform you that maybe you should look for factor 11 as well. But since von Willebrand's can exist with anything, that's usually a safe place to start.
All right, thank you. In the biker you mentioned, her symptoms appeared at 19 years old as bruising, then disappeared. And then what happened? Are you saying that symptoms can appear and disappear then for periods of time?
Yes, absolutely. It's really, I can't explain it. I don't think anybody can explain it, but all of us in this world share the experience of patients who will go through runs of remission, if you will, and then all of a sudden they'll start having problems. So yeah, I can't explain